The esophagus is a 25 centimeter muscular tube located in the mediastinum behind the trachea and in front of the spine. The esophagus passes through the hiatus and connects the hypopharynx with the stomach. The mucosa lines the lumen of the esophagus, followed by the submucosa, the muscularis propria, and the serosa or adventitia. Blood is supplied by the inferior thyroid artery, the aortic esophageal arteries, the left gastric artery, and the left phrenic artery. Venous blood flows into the superior vena cava. The esophagus is innervated via the parasympathetic vagus nerve, as well as the thoracic and cervical sympathetic trunk. Deglutition, or swallowing, is a complex action involving over 30 nerves and muscles. During the pharyngeal phase, the epiglottis prevents material from entering the trachea. A rapid wave of peristalsis propels the bolus through the upper esophageal sphincter. This lower esophageal phase is an autonomous process in which peristalsis propels the bolus at around 3 to 4 centimeters per second. The lower esophageal sphincter is tonically contracted to prevent acid reflux and relaxes only long enough to allow the bolus to pass through into the stomach. A number of conditions can lead to swallowing difficulties or dysphagia, in which movement of food or liquid to the stomach is painful or delayed. Eosinophilic esophagitis is an allergic condition in which eosinophils accumulate in the esophagus, causing inflammation, dysphagia, regurgitation, and loss of appetite. Achalasia is a rare, possibly autoimmune condition in which nerve damage prevents the lower esophageal sphincter from relaxing to allow food or liquid to enter the stomach. The unique anatomy and position of the esophagus makes it vulnerable to distinct forms of injury at the proximal and distal ends. Esophageal cancer is an aggressive cancer with a 5-year survival rate of less than 20%. Squamous cell carcinoma is the most common form of esophageal cancer and is predominant in East Asia. It originates from squamous dysplasia and normally affects the middle third of the esophagus. Alcohol use and tobacco are risk factors and can also act synergistically because alcohol makes it easier for fat-soluble compounds to penetrate more deeply. Gastroesophageal reflux disease, or GERD, involves reflux of gastric acid and bile through the lower esophageal sphincter, which irritates the epithelium and induces metaplasia. Chronic GERD can lead to Barrett's esophagus, a condition in which the stratified squamous epithelium of the distal esophagus undergoes intestinal metaplasia and is replaced by columnar epithelium. It is characterized by the presence of salmon-colored mucosa extending at least 1 centimeter from the gastroesophageal junction. It's diagnosed by the presence of intestinal-type goblet cells within foveolar epithelium. Patients with Barrett's esophagus are at greater risk of progression to esophageal adenocarcinoma. High-risk patients undergo surveillance, but many cases of esophageal adenocarcinoma are only detected at an advanced stage. Esophageal adenocarcinoma is associated with gastric reflux and is characterized by gland differentiation in the context of Barrett's esophagus. It's more common in white men, and incidence is steadily increasing in the US and in Europe. Esophageal adenocarcinoma arises through accumulation of genetic abnormalities, leading to loss of P16 and P53, disruption of the cell cycle, gene amplification, and aneuploidy. Central obesity also promotes tumor growth via release of adipokinins and cytokines from hypertrophied adipocytes. Esophageal adenocarcinoma can be diagnosed by flexible endoscopy with biopsy. Endoscopic ultrasonography can be used to determine tumor depth in patients with localized disease to improve TNM staging. Tumor depth is classified as tumor in situ for high-grade dysplasia in which malignant cells have not spread beyond the epithelium. T1A indicates invasion of the lamina propria or muscularis mucosa, while T1B indicates invasion of the submucosa. T2 and T3 tumors have invaded the muscularis propria and adventitia, respectively. A depth of T4 indicates invasion of adjacent structures, such as the pleura, pericardium, diaphragm, peritoneum, or the aorta or trachea. Endoscopic ultrasonography can also be used with fine needle aspiration to evaluate lymph node metastasis. N0 indicates no lymph node metastasis. N1 and N2 indicate 1 to 2 and 3 to 6 regional lymph nodes, respectively, and N3 indicates more than 6 lymph nodes. Finally, M1 is used to indicate distant metastasis. The approach to treatment of esophageal adenocarcinoma varies by stage. Endoscopic mucosal resection and endoscopic submucosal dissection can be used for early-stage tumors due to the low risk of nodal metastasis. For more advanced tumors, a combination of surgery and neoadjuvant or adjuvant chemoradiation can be used based on TNM stage. Esophagectomy with lymphadenectomy may be indicated for patients with extensive high-grade dysplasia or some mucosal invasion. Prognosis depends in part on the depth of invasion and spread to lymph nodes. Emerging at the junction of the respiratory and digestive tracts and bridging both the thoracic and abdominal cavities, the esophagus is a unique and deceptively complex organ. Dozens of nerves and muscles work together to perform the intricate choreography of swallowing. Disruption of this delicate process can lead to dysphagia or achalasia. Smoking and gastric reflux can induce aggressive neoplastic changes in the esophagus. As a result, esophageal cancer is the sixth most common cause of cancer-related death worldwide. Barrett's esophagus and central obesity increase the risk of esophageal adenocarcinoma, which can penetrate the walls of the esophagus and spread to adjacent structures and lymph nodes. Fortunately, thanks to advances in endoscopy, esophageal cancer can often be detected and treated at an early stage. Thank you very much.